Hello, this is Dr. Verlage again. I am the perinatal psychiatrist that mans the MT-PAL consult line. And I have put together a series of lectures, or I'm putting together a series of lectures. This is the second lecture, titled The Untreated Crisis: Consequences of Ignoring Perinatal Mental Health. At the last lecture, I presented on the prevalence of different psychiatric conditions in women who are pregnant and postpartum. So I think the next step for this lecture makes sense, that we see why we should care. What are the negative outcomes that can come from it? So let's jump in. I think we think a lot when we're thinking about treatment of women who are depressed and anxious, pregnant and postpartum. We think a lot about the risks with medications, which is really important for us to be mindful of: risks for malformations, risks for effects on baby growing, risks for postpartum things, risks for mother during pregnancy. And again, very important for us to consider. But I think a piece of the puzzle that we definitely ignore, or we don't consider as much, and which is actually quite important, are the risks of untreated psychiatric conditions during pregnancy and postpartum. We have lots of studies, which I'm going to go over a few things today, but lots of studies showing that untreated depression and anxiety can lead to a lot of adverse negative outcomes to mother and baby. Some things including low birth weight, preterm birth, preeclampsia. We're going to go into a little more detail of some other things we might see and the studies that show them, or a study that shows it. And we think a lot, this last bullet point, we think a lot about advanced maternal age, so being over 35 and all the risks, and we talk about that. Being of a high BMI, that's something that healthcare providers have to be really mindful of, and the risks associated with that with pregnancy. But there's some data to show that untreated depression and anxiety during pregnancy can be similar or even greater and pose more risk than those other factors. So a really important topic for us to think about, for everyone to think about in the mental health and general health community. So I've split the lecture into risks. One study that shows risks during pregnancy, risks to mom and baby when there's untreated depression and anxiety during pregnancy, and then the risks postpartum. So the study that I think is a good one is the Healthy Babies Before Birth study. And again, this is the during pregnancy untreated conditions. So this looked at both maternal mother's affect and infant development. It was a recruited women between 1 and 12 weeks of gestation from the Denver Health and Hospital Authority, along with Cedars-Sinai in Los Angeles. And it was done between the years of 2013 and 2017. So in this population, they screened women with the PHQ-9 for depression and the OASIS scale for anxiety. They had certain standard cutoff scores for when something was considered a clinical condition of depression or anxiety. And of all the women they looked at, 19% of the women in the study were diagnosed with either perinatal or during pregnancy depression or anxiety that was clinically relevant. So they grouped negative outcomes together. These negative outcomes included gestational diabetes, intrauterine growth restriction, preeclampsia, chorioamnionitis, hemorrhage, fetal death, preterm birth, and low birth weight when baby was born. So looking at the women who were in that population that were considered to have a psychiatric condition, 37% of women in that group experienced a negative adverse perinatal outcome from that list given above. So almost 40%, which is a lot. And this next point really demonstrates how high that really is. That meant that those women who were depressed and anxious were 3.5 times greater risk of developing one of these, of having some negative outcome. So, when we're stepping back and thinking about all of this, women who may have had their conditions, psychiatric conditions, treated would be at 3.5 times less risk of having to go through one of these really impactful negative outcomes, during their pregnancy. And that window for us to step into to try to not only give mother a more positive experience of her pregnancy, but these real medical risks that come if we don't. So, really important for us to be screening and aggressively treating depression during pregnancy. So, shifting to the postpartum period, and I've got a lot more slides on this, but the study I want to look at is a systematic review that was published in 2019, and it evaluated both the baby and maternal consequences of not treating postpartum depression. So this systematic review pulled together 122 studies, so a pretty impressive sample. And they looked at, so let's talk first about maternal physical health consequences of postpartum depression. So looking at mom's physical outcomes, they showed that quality of life was significantly impacted when postpartum depression was going on. So women are expected to gain weight during pregnancy, and there's data to support that being able to lose postpartum weight has positive health outcomes, and women with postpartum depression were at double the risk of not being able to lose weight. 5 kilograms is what they looked at after delivery, so retaining more of that weight. And then they were also more likely to need to engage in the healthcare system and see a primary care doctor or a mental health professional, if they had postpartum depression for anything. So sickness, not feeling well, what have you. They engaged more with seeking help. So those are physical consequences. Psychological consequences, which I talked about in the last lecture, but the Edinburgh Postnatal Depression Scale is the standard scale we use when we're screening for depression in the postpartum period. So EDPS, that's what that's referring to. But a higher Edinburgh scale, understandably, was related to not feeling good, feeling depressed, so less happy, more dysphoric and sad, which in general we don't want too much of. And then those women were also had a significantly longer depressive episodes. And this point I think is really good for us to bring up and talk about, is that there were variables and independent determinants of things that could affect higher chances of postpartum depression and lower mental health scales, which were if there were pregnancy complications, a cesarean delivery, if mom was reporting poor quality of sleep, if mom perceived low social support, having greater life stress. These were all, again, independently correlated to mom having a worse mental health status. So we may not think that somebody with pregnancy complications needs more monitoring, but again, the study would argue that they do, because they're more at risk of developing postpartum depression. Okay, so this is not part of that systematic review, but I did want to include the study in this spot. I thought it made sense, but because we're talking about the mental health outcomes for moms postpartum. So there's been lots, and the systematic review does talk a little bit about postpartum suicide risk, but again, this study came out on MGH's, Mass General Hospital's website, as being particularly interesting and important. So Japan did a retrospective cohort study. They used patients who were already in the hospital and pulled their diagnoses codes. So they found that the prevalence of suicide attempts was much higher, significantly higher postpartum than women who were pregnant. 6.2% of those who were postpartum compared to 0.7% of those who were pregnant. Now, we should always be screening and mindful of watching for risks and signs and statements of suicide, but 6.2% compared to 0.7% is a pretty significant difference just between those populations, let alone, which this last point brings up, compared to a woman who has no psychiatric history. These women who are postpartum and postpartum having depressive symptoms were 300 times as likely to die by suicide after the birth of a child. So that is, a pretty remarkable number. And yes, these are two very different populations, but it just goes to show how dangerous this can be if we're, not being mindful and screening for all this. Now, this is still a low absolute risk, 6.2% of inpatient hospitalized women, but, so getting to the hospital, and that's still not the highest number. But again, these are, when you look at it en masse, and to think that there are treatments to prevent this from happening, we do know that this risk is much higher than for your average person, and something we should really be screening for. Okay, so back to that systematic review that I was talking about a little bit ago. So we went through mom's physical health, mom's mental health. Now let's talk about mom's relationships. So all of which suffered. So they looked at mom's relationship to their partner, which those scales were lower. The mom's relationship to baby. So when they had a depression, they screened positive for depression 10 days postpartum. They, throughout the whole first year, had lower rates of rating their relationship with their infant. There's also a scale called the maternal positive communication scale that looks at, how mom interacts with baby and communicates with baby, and the higher number the better, but those numbers were lower for women who were struggling with depression. So that was all of mom's points. Now baby's points. Postpartum depression effects on infant health and development. Now, a lot of these have to do with growth rate, so bear with me how they kind of slice these up. But infants of depressed mothers showed low overall weight gain and an increased rate of weight faltering from birth to 4 months. Then they stratified the next one as infants with mothers suffering from postpartum depression have lower weights overall at 6 months, higher maternal depressive symptoms at the 5-month mark were associated with less weight gain from 5 to 9 months. Now, the rest don't have to do with weight, but they present it like this because there were so many studies that they looked at that had different time intervals that they were looking at, but pretty across the board. Babies didn't gain weight as well when mom was depressed. And we really see baby weight gain as a sign of, baby growing well. It's one of the main things that pediatricians will look at throughout the first year of life is that they're gaining weight well. So it really is a sign of infant health. And the fact that that was not doing as well with depressed moms really goes to show how, that can be impacted. It's a good marker for overall health. So, and low weight can come with a number of negative health outcomes, or not gaining weight as one would expect or hope. In addition to struggling with weight gain or more when mom's depressed, babies had more diarrheal episodes when mom was depressed. Babies weren't sleeping as well. They had increased infant nighttime awakening. It was also, maternal depression was negatively impacted motor development in children, and along with language development. So across the board, we're seeing, how mom not feeling good, mom struggling with depression makes giving these babies what they need really challenging. And this first year, is prime time for depression. We've given it its own name, postpartum depression. So mom's more at risk for all the awful things that come with depression, and baby, that first year is really impactful for the rest of their lives, for them to meet these milestones and grow and eat what they need to, what have you. So, us leaving this untreated really negatively impacts baby long term, which we'll talk, again, I think that these slides in and of themselves are demonstrating, but I think from this slide, that first year has a lot of milestones to think about, a lot of, milestones to meet, weight to gain. Every day, every month matters a lot, and when mom can't do what she wants or needs to do, it can be really tough. So there's also kind of the third factor, mom, baby, and then the bond between the two of them, which a depressed mom, you would imagine it's much tougher for them to do. So no surprises, depressive symptoms were, there was a direct association with mom's emotional bonding to the infant, which inherently means an impact on maternal bonding. Lower bonding results were significantly predicted when mother's depressed, and also has a lower education level. That's a good thing for us to think about whenever we're working with moms, and how to help and what to screen for and watch for. I mentioned that maternal positive communication scale. That was also impacted by postpartum depression, which might be a little repetitive because that was brought up. But I think this is pretty, again, these scales are this, how many times more likely we are to see any of these things. And it was 5 times more likely when mother was depressed for her to experience poor bonding. So there's other studies that show the effects of bonding long-term with mom, emotional development of child, what have you. But obviously bonding is really important, and that mothers aren't getting to bond like they would be because they're not getting treated is really tragic to think about. So, obviously we need to go in, and I'm going to talk in this next slide, and help get access to psychiatric care. But there's other things to think about with, patients struggling with postpartum depression, and that we can assist and intervene with. So a couple things is they showed that postpartum depression, mothers were less likely to put infant to sleep on their back, which we know is important to prevent SIDS, to use a car seat, which is important for obvious reasons of not having baby get hurt or die in a car accident, and to have a working smoke alarm. So asking about these things specifically, helping moms be able to do these things, can be really helpful when we're working and getting moms treated for postpartum depression. I think these are good things for us to check in on. This one I say with a grain of salt, or with a, with a lot of opinions, but moms who are depressed are more likely to discontinue breastfeeding. We want to support moms in their goals. If breastfeeding is one of those, we should help. However, I do think that we need to normalize that it's just some moms can't breastfeed. Sometimes it's just not right for the family. So what I really try to avoid is have moms feel shame if it's either not happening or can't, or logistically just not best for them. Formula is perfectly healthy and fine, and we shouldn't add stigma or shame to women who aren't able to or logistically can't. So, but giving them resources, extra resources to help them breastfeed, knowing that that's going to be more tough for women who are depressed and struggling with postpartum depression. And which I've kind of sprinkled throughout the talk, all of these negative outcomes, I think it's pretty clear they're there on many different, in many different ways. Postpartum and pregnancy, or depression and anxiety during pregnancy, all of that is treatable. So we can help prevent all these negative outcomes if we can get mothers to help and on treatment if it's going on. From my last presentation, most women do not receive anywhere near adequate treatment, even with therapy, medication. They just don't. So we really need to be proactive about getting programs, getting providers to screen for it, educating about how to treat it, just helping these moms get help early so we can prevent all these negative things from happening, and helping moms, have as positive an experience as they can with pregnancy and postpartum. This is a really special time, and to have that robbed from mothers and babies because of depression, I think it's really awful. And if it's preventable, we should do everything we can to help. So that wraps up this lecture. Please reach out to me if there's any questions, and I'll see you at the next one. Bye.